Okay. Okay, I started. Go.
Okay, so we're gonna start with the anemias and then go through the cancers and the oncology emergencies first, because that's the majority of the test. So we'll just start with the diagnostic testing for anemias. So we know that hemoglobin is the oxygen carrying capacity and the hematocrit is the percent of how thick the blood is. And the way that we can see the differences in this is through the red blood cell indices. So that's what the MCV means on the, when you're looking at the differential. So if an MCV is large or big or says megablast, then that means the red blood cells are really big. So we see that in two conditions. And then if MCV is low, we see that in pancytopenia, means that red blood cells are low. So we'll start with aplastic anemia. So aplastic anemia, they said to think of it like your bones are plastic and you're gonna throw them in a pan. So if they're plastic, everything's low. So pancytopenia, so you think that red blood cells, white blood cells, and platelets are all low. That's what pancytopenia means. And that is—
We talk about, hold on, which one is that one?
So aplastic anemia. That's
okay, aplastic. Okay, okay.
So you can think of it like you're plastic and throwing it in a pan. So for pancytopenia. And there's a couple different causes for aplastic anemia, but the one she told me to really star and look at was the toxic agent benzene.
Yes.
So it's on the PowerPoint. It's BENZENE. So
sorry, Audrey. Maria, it says for Lexi's computer that you have to let her in.
Yes, I know.
Oh, okay.
I didn't see her. Yeah.
Thank you. Okay.
She's coming.
Sorry, Audrey.
You're good. So, and then the other major causes of aplastic anemia would be an autoimmune reaction or following a viral infection. So those are going to be the three major causes of aplastic anemia, but she said to really focus on that toxic agent benzene. And then the treatment for aplastic anemia is going to be a combo treatment. So this is where we have, and I am sorry, I do not know how to pronounce these things. So I pronounce them however I read them, but it's the anti-hemocytic globin solution plus the cyclosporin. So that's the combo. And because that combo causes sickness, you're going to also give a corticosteroid. And the corticosteroid is what helps decrease the inflammation from the combo treatment. Mm-hmm. And then if it's really severe, you would do a splenectomy and remove the spleen. Because she said the spleen is like the trash can of all of the cells. Mm-hmm. And so if it goes there, you would need to remove it. Mm-hmm. Let's see. So she said to really focus on that treatment. She thinks that those drugs will be on there, that combo treatment and giving the corticosteroids to decrease the inflammation. Mm-hmm. So that was the major thing she pointed out for aplastic anemia. The next one is the iron deficiency anemia. And the two major causes are going to be blood loss or inadequate intake of iron. So you're either have a bleed somewhere or you're not intaking enough. And this is the number one, this is a big thing in GI bleeds because GI bleeds can lead to anemia and they can be hard to find. So that can be part of the blood loss there. You can think of GI bleed. With this one, you're going to be extra tired because the iron, it will have a decreased oxygen carrying capacity in the blood, so you'll feel more fatigued. And the treatment, she said to focus on this one. She said on the test, they probably won't call it iron. They're going to call it the oral ferrous sulfate if you're going to take it orally. We know that if we're going to give it IM, it has to be by Z-track. And the big one is if they have kidney disease, you have to give it IV, and it's the furomoxetol. So that she said to really highlight that if they have kidney disease, they have to have it IV with that, however you say it, the furomoxetol. So those are the big things for iron deficiency anemia. And then she said to know the foods that they've been on the last couple quizzes. If there's a diet question, to focus on the spinach, green leafy vegetables, dried fruits, and organ meats. So if they're going to start with diet management, think about those, but they'll probably say oral ferrous sulfate, or if they have kidney disease, IV, whatever that's called, furomoxetol.
The question which was in our quizzes was the most important or the most whatever, and were only the organ meat and the apricots. Was tricky question because the greens could be there too, but actually it's not. That was a tricky question.
And they kind of try to confuse you with, like, I've seen asparagus on a couple of questions now, and that one's not it, and Brussels sprouts isn't it.
But I looked on the internet, and actually they are used, especially the asparagus, it's used for the low iron because only one spear has quite a lot amount in it.
Okay. Because
I searched it on the internet and I was like, okay, the asparagus for sure because has high quantity. But
yeah. Well, hopefully we'll just focus on those two, the kidney IV one. Okay, so then the next big one is the pernicious anemia. And this one has 3 names that she said we might see it by. So it might be called pernicious anemia, or vitamin B12 deficiency anemia, or she might call it megaloblastic anemia, because this is the one where the MCV will be large. So that's why it's megablastic anemia, because the red blood cells are really big. Does anyone have Lorena Soto's phone number? She is texting, asking if she can get on. Can you text her the link?
I'll send it to her.
Okay, thank you. So with this one, it's really important we might get a differential chart and be looking at the sizes. And this is one of the ones where the MCVs will be increased or large or more. She said there's lots of ways they could say that. So just to think about it like that. With pernicious anemia, they lack intrinsic factor, which is found in the stomach. And so people who could be at risk for this would be someone who's had like their part of their stomach removed, or weight loss surgery, or a cancer in the stomach, anything that could affect the stomach. It would affect the intrinsic factors. And you need intrinsic factor to be able to absorb vitamin B12. So that's why they would have it. The big thing with pernicious anemia is that it can cause CNS disorders. So you're going to think of anything with the paresthesias, like the peripheral neuropathies, or they can be off balance. And then the other 2 big signs, they're going to have jaundice, and they're going to have the glossitis, which is the sore, beefy, red, smooth tongue. So this is the one. There's one other one where MCVs will be, Megan says she's trying to get on.
Yes.
Right? Okay. The MCVs will be large in aplastic anemia and in folic acid deficiency. They're very similar, but in folic acid deficiency, you don't have the central nervous issues because they still have vitamin B12.
Yes.
So that's the two differences in there. But otherwise, they're very similar. They're similar in signs and symptoms, but the only difference is the CNS issues. But they look the same on a differential. They're both the big red blood cells or the large MCV. So for aplastic anemia, the treatment, the main two treatments, she said she's probably going to spell this out, and I don't know how to pronounce it, but it's the cyanocobalamin.
For the B12.
Yes, B12.
Okay.
She's going to spell out the long word that starts with a C, the cyanocobalamin. And
Yeah,
that's,
you have it in the notes.
yeah.
Cyanocobalamin.
And so you're going to get that once a month by injection. And that's enough to carry them. The other way you might see it is in the Colamist, which is the nasal spray. The reason that you don't give it orally very often is because it doesn't really help, because it's water soluble and you can just pee it out. So that's why they try to give it by injection or nasal spray first. The test for pernicious anemia to see if it's this kind of anemia versus anything else is going to be the Schilling test. And that's where they give a dose of radioactive B12. And if they don't pee out the radioactive B12, then you're positive for pernicious anemia. So she said that that will probably be on there. So if they do pee it out, they don't have pernicious anemia. So I think that that's the big ones for that. With all the anemias, she said that she might try to trick us. Everything, with all of them, you'll be pale, weak, and fatigued. So look for the big signs that are individual to each one. So this one, it's the beefy red tongue, the paresthesias, and the jaundice. Okay, so the folic acid deficiency, this is the one where you're going to think alcoholics or malnourished. So on this one, it looks really similar to pernicious anemia. It's going to have the large MCVs, but they're still okay with all the neuro things because they have the B12. So think alcoholics, and think the first thing you'd want to fix is their nutrition for that one because they're malnourished. The two main causes are poor nutrition, drugs, and alcohol. And the prevention is to help them assess and identify their dietary habits. And then it can be managed with folic acid replacement therapy.
Okay, malnourishment, alcohol, and drugs.
Yes.
Okay.
All right, so for the hemolytic anemias, she said there's just the two from the PowerPoint we need to know: the hereditary hemochromatosis, and that one means that you have too much iron. And she didn't really go into specifics about it. She just said hereditary hemochromatosis is too much iron. And then the next big one is the sickle cell anemia.
Okay, hold on. Which one? Where do I find the one which you're talking about?
It's on the PowerPoint. She didn't add it on the blueprint. Tammy pointed it out because it was the only one that was kind of opposite of the others. So she didn't know if it might be on there. It's on the PowerPoint under, so there's folic acid deficiency, and then it goes hemolytic anemias.
Okay, that one. Okay.
So hereditary hemochromatosis.
Okay.
All right, so for the sickle cell anemia, Tammy said to think of it like it's a moon shaped and it hops. And so the treatments, you're gonna hop over the moon shaped. So hydrate, oxygen, pain control, and symptom control. So think of those as your nursing care things that you're gonna do for them, hops. She's,
Audrey, can you say that again? Sorry, the treatment.
yes, HOPS, like HOPS. And it stands for hydrate, oxygen, pain control, and symptom control. So the other things that she pointed out to remember about these are that sickle cell anemia is congenital and that it's most common in African descent and Mediterranean descent. The patient education, it's kind of a long list for those, but I can read them. I don't know if this is helpful. If it's not, just tell me. But it's to drink 3 to 4 liters per day, because that's part of the hydration. You're going to avoid alcohol, smoking, and tobacco. You're going to make sure you're up to date on all your vaccines. Avoid the extreme temperatures of hot or cold. And you're going to avoid high altitude because that can cause a sickle crisis. And you're going to do moderate, low impact exercise 3 times a week when they're not in crisis. So that would be like the swimming. Then we have the bleeding disorder checklist that we should also teach that goes along with that education. And the ones that Tammy had me underline was that we're not going to use any suppositories, enemas, or tampons if they have any kind of bleeding disorder. We also need to avoid constipation, so we're going to increase fiber and use a stool softener. If they do have a bleed, we're going to teach them to use a cold compress. Unless it's a hematoma and the blood is like pooled in an area, then we would use a hot, like heat to help it dissipate out of that area. So you always use cold to stop a bleed, but if it's already pooled in like a hematoma, then you can use heat. We need to teach them the signs and symptoms of a bleed and to use an electric razor and a soft bristle toothbrush. So those were the bleeding disorder checklist items. All right, now we have hemophilia. So we have hemophilia A, which is the deficient factor of 8, and hemophilia B, which is deficient for factor 9. And Tammy said to point out that hemophilia A can also be called Christmas disease. And I didn't see that anywhere on here, but she had it underlined like 3 times. So I just wrote it down. So if we see Christmas disease, we'll know hemophilia A.
It's in the book. That's where I saw it at.
Did you? Okay.
But I don't know why. I mean, I kept in mind that it's B, not A.
Oh, it's in our PowerPoint too. Our PowerPoint on page 18.
Yeah.
Bleeding disorders. Yeah, it has the Christmas disease under there.
Yeah.
But which one? It's A or B? Because I kept in mind that it's B.
On the PowerPoint, it's just kind of underneath, so it's hard to tell. Tammy told me 8. Maria, can you let Agatha in?
Yeah.
Okay.
Thank you. I don't see because it's below. If it's
yeah.
Okay, go ahead.
Okay, so for hemophilia, the important things that we need to remember, the signs and symptoms, we're going to have bleeding in the joints with 75% of them. And hematomas are going to be in the muscles and the soft tissue. And the first treatment is to give them prophylactic factors. So we're going to give them the factor 8 or factor 9. And we need to teach them how to do that at home because they can give it to themselves. So the patient education, we need to teach them how to live safely, how to take their factors prophylactically, to wear a medical ID bracelet. Don't take any NSAIDs, so no aspirin, no ibuprofen, no alcohol. They need to do good hygiene. And then when a bleeding episode does start, they need to use cold. Tammy said she pointed out to me that we know that it's X-linked, so mom to son, but the women still have hemophilia. They're just asymptomatic. So women have it and pass it on, but they're asymptomatic carriers, where males have it, have the active disease.
I just received your messages, Agatha and Megan. Just come now.
Thank you, Maria.
Let's see what else about hemophilia. So if it's mild, we might find it later when they're in adolescence and they started sports. So we can find it then, but if it's a pretty severe disease, then we'll find it early in childhood. And all right, I think that's it for hemophilia.
Okay.
Then the next bleeding disorder is DIC, or the disseminated intravascular coagulation. And she said to think of it as death is coming, because it's very serious. And it can be an oncology emergency, so it can happen after chemo, or it can just happen spontaneously from a viral illness. That's why she put it in the coagulation disorders, but it's also an oncology emergency. So what happens in DIC is, first the body starts to clot off all the organs. So it is trying to protect the organs, so it starts clotting, but then it realizes that you're clotting too much, and so it bleeds out really fast. So you go from having all these clots to every major organ to bleeding out. And the lab test that you're going to use for DIC is the D dimer. So we'll look at the D dimer. I don't know that we'll have to know any numbers. She did point us to page 931 where it talks about D dimer, but I'm just remembering D dimer. Then Tammy had me go over heparin, and low molecular weight heparin would be what they would use first if the patient was clotting. But then because they clot and we don't know when they're suddenly going to start bleeding, then the antidote is the protamine sulfate. So we need to keep watching for that. So you don't want them to clot because that can kill them. But as soon as they start bleeding, you would need to give the antidote.
Which is the antidote?
Protamine sulfate. The other issue we need to look for is while they're on heparin, they can get the heparin-induced thrombocytopenia, or the HIT. And the clotting factor that we need for that is the fibrinogen. So if they're having the heparin-induced thrombocytopenia, that's when you would give fibrinogen. Sometimes when they're in DIC, they will start them on the heparin, but then give the warfarin because warfarin takes longer to start working, and they would go home on warfarin. And so then the clotting factor for warfarin is the vitamin K.
If I didn't, if you were not here, I would not even look over this.
Well, I hope it's helpful. This is what I went over with Tammy. So
I know.
I hope we're studying the right
not on the list, you know?
Yeah.
Oh, yeah, will you let Lorena in?
Okay, so the next thing we can do is the transfusion safety. So this is the blood transfusion safety.
Okay. Hold on. I need to open it there.
So for the blood transfusion safety, we are going to always remember that blood products can only be given with normal saline, and that we never warm blood products, and we never add any medications to blood products. So for our checks, we're going to have a 2-nurse checks. They have to check all these things. So both nurses have to check the ABO group, the RH type, the patient's name, the hospital number, and the unit of blood. So there's 4 things that both nurses check.
Okay, the ABO.
The ABO, the RH, the patient's name, and the ID blood on the actual bag.
Okay.
So we're going to give the blood within 30 minutes of getting it from the pharmacy, and we're going to do the total infusion in a 4-hour window. And then we're going to do vital sign checks every 5 minutes for the first 15 minutes. And then at 30 minutes, and then from there we can do it every hour. Then the complications of a blood transfusion, we have the febrile non-hemolytic reaction.
Okay.
And with the febrile non-hemolytic reaction, there's 2 signs and symptoms. We could see fever or chills. And then if we have the acute hemolytic reaction, this is the life-threatening one. And so this is the one that has more symptoms. And she said the first one they're going to feel is the flank pain, or the lower back pain. They will also have fever and chills, but then their chest will start getting really tight, and they'll have the dyspnea and anxiety. So the first one, just think febrile, fever, chills. And the second one, think life-threatening, and you'll have the flank pain and the chest tightness, and you can't breathe. A fever after a blood product is considered 1 degree higher than their baseline. So you should take a temperature before, and if it raises just 1 degree above whatever their baseline is, that's considered a fever after that you would look for. The first thing we're going to do is stop the infusion, and then we're going to make sure that normal saline is going in a new tube. We're going to assess their signs and symptoms, and then call the doctor. So call the doctor is not the first thing. Go ahead. Do you want to say something? Or
can you repeat again what you were talking?
about what you would do?
Yeah.
So first you're going to stop the infusion.
Okay.
And then you're going to make sure that normal saline is going to start flushing it out. And then you're going to assess their vital signs and their signs and symptoms, make sure that they're breathing and all of those things. And then you call the doctor. So it's actually the 4th thing you do is call the doctor.
If they have a symptom of allergic reaction.
Yeah. And then you would notify the blood bank and send the blood back with the tubing. Then there are 2 transfusion associated issues. And so one of them is the taco and the trolley. So in the taco, that's the transfusion associated circulatory overload. So you can just think circulatory overload. They're going to have signs and symptoms of being overloaded. So their blood pressure is going to increase, heart rate's going to increase. They're going to have the JVD and the crackles in the base of the lungs, and it can turn into hypoxemia and pulmonary edema. And so for this one, the treatment is to stop the infusion, to sit them upright and put their feet in dependent position. And I had to ask her what that meant. She said, just like you're sitting in a chair, so your feet are down.
Mm-hmm.
So that's all for that one. You can just think overload, they're overloaded with fluid, they're overloaded with all the things. So think what you would do. You would sit them up so they can breathe, and everything would be high.
In the PowerPoint presentation, it's wrong. She wrote hypovolemia. It's not hypo, it's hypervolemia.
You're right.
Okay.
Yeah, hypovolemia doesn't even make sense. You're
No.
overloaded, so you have everything is too much. I didn't even see that.
Yeah.
And then with the trolley, that's the acute lung injury. So with this one, you're going to see this within the first 6 hours of the transfusion. So it'll be pretty quick. And this one, you're going to have shortness of breath, hypoxia, hypotension. So the other one was hyper, this one's hypotension. And then you can have the fever with this one. So I think that's the big difference, the hypo and hypertension, and the other one, you're overloaded. This one, it's not necessarily overloaded, it's just an injury. The other thing she said about this one, the trolley, you are more likely to get if they're receiving plasma or platelets. And with the taco, that can be with any blood products.
Yeah. Why do you think she put obtaining plasma and platelets from men? What does the man do in order for us to have this trolley? Look, when I read, I was like, why she specific put men there?
Does anything make sense with Jones?
Yeah, they have more germs. That's true. It's true, Morad?
No. Does anything make sense with Jones is what I said.
Jones, yeah, I don't know.
Oh, with Jones. I thought with germs.
That too, probably.
Okay.
Okay, so that's all I know about that one.
Okay. It's good.
Okay, so now we can go to the cancers, if that's okay.
Okay. It really helps us what to focus on. At least for me.
That's good. Okay, so I have the cancer PowerPoints and then going off of the blueprint. So we'll just start at the top. Start with the PowerPoints. So the first thing about oncology, she wanted us to know the pathophysiology. And so knowing that the cell is transformed by the genetic mutations of the cellular DNA. And so basically you have an uncontrolled growth of abnormal cells, and that uncontrolled growth is damaging healthy DNA. So if you have a benign growth, then it's growing locally and it's not going to spread. If you have a malignant growth, then it invades and takes over other organs. So benign is local and in one spot, malignant is taking over. For the prevention, we have primary and secondary. So with primary, you're going to think about things that you can increase protective factors and decrease the risk factors. So you're going to increase protective factors like eating low-fat foods, fruits and vegetables, wearing the wide-brimmed hat, long-sleeve shirts, and sunscreen. Mm-hmm. And then, the protective ones were eating good and exercising. The avoiding risk factors are the sunscreen, hat. Don't go out in the heat of the day. So she listed the daytime on here. Let me find what I put real quick. 10 a.m. to 4 p.m. is the heat of the day that we should avoid. The sun. Then the other health promotions for cancer that we can teach, we're going to teach to avoid tobacco, limit alcohol, be active. And Tammy pointed out that we need to, she listed specifically how to be active. So adults need 30 minutes a day and kids need 60 minutes a day with at least 3 days of vigorous exercise. We need to teach safe sex and getting the HPV vaccine and limiting to one partner. We need to teach to get physical exams and to get, as part of the secondary, this is where the secondary health promotion fits in, it's to get screened and have early diagnosis. So this is, we're gonna get pap smears, mammograms after 40, and colonoscopies after 50. And she didn't put the tertiary on the blueprint, but that's just if you already have cancer, what you're gonna do. So it just goes primary, secondary, tertiary. And then for the risk factors, the ones that are modifiable are diet, exercise, tobacco, and lifestyle changes. The risk factors that are not modifiable are age, sex, family history, and ethnicity. We don't have to know any of the cancer diagnostic tests or any of the staging, so that's good. Okay, for the psychosocial care of a cancer patient, it all builds to a thing. Maria, can you let Lorena on?
Yes, thank you.
So it builds to hope and communication. So that's like the big thing, but then these are the things that build up to the hope and communication. So the first one, you're gonna have the recognition phase. So that's the first time the patient realizes they have a issue. Then the second, they're going to receive their diagnosis. And so they're going to respond to the diagnosis. Then they're going to create coping strategies. And it's the nurse's responsibility to accept and acknowledge the patient's individual coping strategies. So that's where the hope and communication comes.
Did you read there in the down where she tells the concept of providing false hope, it's outdated. Encouragement of hope is crucial.
Yes.
Which means that you have to give hope to people no matter what.
You give them hope, but not false hope. So if you have the PowerPoint on this slide, she has a whole bunch of notes that she added that you can read. So I don't know, it's really small and there's a bunch under there, but I think just knowing that you want the hope and the communication, that's what Tammy pointed out. Okay. So the goal of cancer treatment and management, it's three parts. So you want to cure, control, and palliation, which I asked her, that's just like palliative care. So just think what you would do for them. So that's the goal, is to cure, to control, and palliation. So let me find where we're at there. Okay, then on the blueprint, she listed all the treatments of cancer. So we have surgery, chemotherapy, radiation, and the stem cell. So we can just go through each one, and then I can tell you what Tammy kind of pointed out for each of those.
Okay.
For surgery, she said we need to think about airway and edema. So if you're going to be doing any kind of surgery for cancer patients, you always think about how are you going to protect their airway, and then watching for edema afterwards. So especially like on the esophageal cancers, then they can't swallow, and so you're watching for both of those, swelling and airway. Then for the radiation, she focused a lot on the EBRT, the external beam radiation therapy. So the goal of EBRT is to have a local regional tumor controlled without as many side effects. So you're not going to have the systemic side effects. And it's the EBRT is the most common type of radiation. You will still have fatigue and tiredness because that's a general cancer issue. So that's the only systemic one that she talked about. Otherwise, it's just local issues. And then Mrs. Jones gave the example, if you were going to do radiation near the head or neck, you would think, what would it affect? And it could affect confusion or cerebral edema. So you could think about what you would do for those. Then for the radiation side effects, this is where they can have the erythema or the dry or moist desquamation, however you say it, the desquamation. She showed us those pictures of like the skin just kind of falling off and peeling. And so we've talked about how we would treat those. If it was dry, we could probably treat it at home. It gets itchy and inflamed. But if it's really wet or if it's on the chest, they would be treated in the hospital. And we would give them a PEG tube for feeding to let it heal. We're not going to use any lotions because that can make this side effect worse.
Yeah.
And then if it was near their throat or esophagus, we would give them the suction yonker so they could suction themselves if they needed to. Then the big one that Miss Jones pointed out, and then Tammy reminded me, that those are acute side effects to have the desquamation, but the long-term side effect is something like dry mouth. And she might call it that xerostoma, so it's spelled with the X. And what we would do for that, if they had dry mouth and they had a hard time swallowing them, we would tell them to put gravy on their food. I was like, oh, that would be really gross. But she said that could be a test question. So if they had long-term dry mouth, think about what you would do to help them swallow better. So using gravy on foods and telling them to keep water on hand because it's really hard for them to swallow.
Okay.
Brachytherapy is when you implant the radiation. And so this is, you can think of anything that has a cavity. So they can implant it like for cervical cancer, they can implant it wherever there's a cavity, they can put the brachytherapy. The big ones that Tammy told me to think about for brachytherapy is actually not about the patient, it's about the nurse. So you're going to remember if that brachy therapy falls out, you'll never pick it up with your hands. You have to use the forceps, the long handle forceps, and then you're going to take it and put it right away into the lead container that they keep in the room. So never pick it up and then put it in the lead container. The radiation safety principles, there's 3 of them. So you're going to decrease the time. So that's decreasing the amount of time you're near the radiation. You're going to increase the distance. So if you need to talk to them, you can use the intercom or stand at the door. And you're going to use a shield device or an apron when you're in the room. The little personal device that nurses wear is called the, I don't know how you pronounce it, dosimetry badge. So the nurse wears that and you never share it with anyone else. So Tammy said you keep it because you wouldn't pass it to another person. It's to see how much radiation you have taken on. So you wear a little badge and it keeps track of how much radiation you've received. So those are the radiation safety principles. If someone is in a room and they have a brachytherapy radiation device and they need CPR, then you need to double glove, gown, and shoe covers before you go in the room to do CPR. And then you'll have to go down and make sure you're not radioactive before you leave the area. I don't know how teachers teach. I haven't enough to drink like a gallon of water.
You're doing so good.
I hope this is helpful. Okay, so then for chemotherapy, The chemo agents are going to kill the DNA or the RNA, but they don't discriminate from cancer to normal cells. And so their target is to kill the fast-growing cells. So fast-growing cells are going to be hair, nails, mouth, skin, and bone marrow. And the bone marrow is the dose limiting factor. So if it's killing the other things, we'll keep giving it. But if it's killing too much bone marrow, that's when they stop. So that bone marrow is the dose limiting factor because they don't want it to kill off all the bone marrow. So Tammy told me they'll let it get to like 10%. They'll kill everything but 10%. So that I was surprised. I was like, wow, that's pretty low. And then the safety administrations, there's a PowerPoint called Safety Administration about chemo, and she said we need to know the whole list.
Okay.
So the first thing, we have to have consent to give chemo. We have to review the order and double check it. We have to check the dosage, review the drugs, administer any pre-medicines. So if we know that they are hypersensitive to anything, we will pre-medicate them with an antihistamine because we still want them to get the chemo. So that's one of the things we would pre-medicate with. We'd also pre-medicate with antiemetics. And then we're going to choose the optimal site to give the chemo. And while we're administering chemo, we're always going to double glove. And she told me to really highlight, we will double glove for 48 hours after the chemo when we touch any of their bodily fluids. So that includes any urine, or if they throw up or anything like that, you need to be double gloved for 48 hours. And then we need to dispose of the chemo properly. And if there's a chemo spill, then we would call and they do their biohazard stuff. Okay, so the next couple slides, Tammy really explained these to me because I feel like we didn't even cover these in class. A vesicant is the chemo drug. So the vesicant, when you see that, it's vesicant. Vesicant is the chemo. And because chemo is a vesicant, it can cause blistering or tissue necrosis, which is more than just an irritant. So if an irritant got on your skin, it would just be local and red, and it would just irritate the skin. But if chemo got out of the area it needed to go, then it would cause blistering and tissue necrosis. And she showed that picture of like the arm that was starting to have necrosis. So that's what the vesicant does. And then that goes to the next big word, which is the extravasation. So if the vesicant gets into a tissue, it causes extravasation. And this is where you have the red, painful, fluid leaking necrosis. So for an extravasation, you would take something and try to get out as much as you can. So Tammy said you leave the IV needle in, but you would actually suction it like backwards and try to pull out some of the chemo agent that was there. And then you would apply cold. And she said this will be a test question to highlight it. You always apply cold unless it's a vinca alkaloid. And that's in the PowerPoint.
Yes, the 41.
Yes. So for the extravasation, apply cold unless it's a vinca alkaloid, and then you would apply heat. And then you're going to apply a compress to the area every 4 hours for the next 24 hours. And you're going to put an armband on the extremity that has the necrosis to alert other staff. Okay, we talked about safe handling of cytotoxic drugs. So those are your chemos. So
I have a question really quick. So you said the vesicant is the one that you would do like the heat? Or you lost me a little bit there.
Okay, so the vesicant is the chemo.
Okay.
And if the vesicant causes extravasation, which is where the chemo makes it get necrosis, then you would apply cold. So it's the E word. I might not be saying it right, but it's EXTRAVASTION, the extravasation. I don't know for sure how you say it. So if the chemo, the vesicant is the chemo, if it causes that extravasant, then you apply cold.
You said unless it's in...
Unless it's a vinco, oh, I just lost it. How do you say it?
Yeah.
A vinca alkaloid.
That's when you do it cold.
That's when you would do heat.
Okay.
So
Okay.
you would use, you would use cold for everything except the vinca alkaloid, then you would use heat.
Thank you.
Okay, for the hypersensitivity reactions, she put a chart from the book, and it's chemo by body systems that could cause hypersensitive reactions. And it's in the PowerPoint too, but it's straight from the book. It looks like that. And she said to look over that chart and the different body symptoms and clinical manifestations that they can cause. But the big thing is to stop the infusion.
Okay.
So if she said this is the order that we would deal with a hypersensitivity. We would stop the infusion, we would assess the patient, we would flush it with normal saline, and then if we knew they were allergic before we gave it, then we would pre-medicate with the antihistamine. Okay, this is a drug that is in the PowerPoint that Tammy told me to highlight, and I don't know how to pronounce it, so I'm going to spell it. It's the RITUXIMAB, rituximab.
Where do we go to see that one?
It's on page 45 of the PowerPoints.
Okay.
So it's under hypersensitivity reactions, and she said to underline the rituximab. This is the corticosteroid that we could pre-medicate with.
Okay.
So we would pre-medicate with the rituximab and then proceed to give the chemo agent. So it's the corticosteroid we could use for a hypersensitivity reaction. Okay, the side effects of chemotherapy, the one that we're most worried about is the myelosuppression. So that's bone marrow suppression. And we're worried about that because it's our dose limiting factor. So we're going to be watching the leukopenia, the anemia, and the thrombocytopenia. So we're watching all of those because if that goes below that 10%, then we'll stop the chemo. The other side effects she said to focus on, if she says cachexia, just to remember that's like the muscle wasting when they look really anorexic. And then the mucositis and the esophagitis and the stomatitis, those are all the mouth sores and esophagus sores. And so she said the thing that we're going to teach for that is to chew on ice while they're giving the chemo, and that seems to help. And then also teach them not to use any alcohol or mouthwashes that have alcohol in them because they'll burn those sores.
For this reason was do not use commercial mouthwash, and I didn't really understand why. It's the alcohol.
So that's why she talked about the commercial mouthwash. That was on one of the quiz questions.
Yes.
Because it will hurt the sores.
Mm-hmm.
Okay, so this next little thing I'm going to say really quick. It's not on the PowerPoint, but you know those like ONS fast facts that she gave us? She forgot to give us one, and it's really important. It's about the NADIR, the nadir, and she mentioned it in class, but she didn't give us the fast facts about it. But the nadir is the lowest point after chemotherapy, so it's when the counts are the lowest. So
Yes.
this happens 7 to 10 days after chemo is given. That's the lowest point. And during nadir is when we will see pancytopenia, when everything is low. So during nadir, or this lowest point, we're going to do two things. We're going to check a temperature daily, and we're going to report a fever of 100.5 or greater. Call the doctor immediately. That's the first thing, is to call the doctor. And then the second thing, this is where we need the need to know medication charts. So the second thing we're going to do is order a colony stimulating factor to stimulate the bone marrow to produce. So on our need to know medication list, there's 4 stimulating bone marrow medicines on there. So we have the erythropoietin, so that's what we would order if the red blood cells were low. And erythropoietin is also called Epigen. And then to stimulate the bone marrow to produce white blood cells, we have 2, and that's the GCSF and the GMCSF. So those are the granulocyte colony stimulating factors. And their actual names are Granix, so you can think Granix for the first one, and Sagromostatin. I'm so bad at pronouncing.
Okay. It's okay.
It's Sagro something mostatin, and that's the one to stimulate leukocytes. And then the fourth one, if we needed to increase platelets, we would give the thrombopoietin, and that one's called TPO. So at the nadir, we're going to check for temperature, and we're going to order the colony stimulating factors, and it'll be one of those 4, depending on what's low.
Actually, in class, she told there will be on an exam, because I have it written on exam, the colony stimulating factors too.
Okay.
Yeah, for sure.
Okay, then there's a slide that says organ toxicities, and
Yes.
it's like kind of all squished together.
Yes.
But on that slide in the middle, there's a drug called oxaliplatin. I don't know if you see that. It's right above the neurological organ toxicities.
Yes.
Okay, so it's OXALIPLATIN. And this, Tammy said, just think this causes peripheral neuropathy. So this is one of the organ toxicities that we need to watch for, because it's irreversible. So if they have this permanent peripheral neuropathy, we'll have to think safety. So help them to the bathroom, use their call light, all of those things. And that was the only one she told me to highlight on that page, so I hope it's good enough. Okay, the next one on the blueprint is the HSCT, which is the stem cell transplant.
Mm-hmm.
There's 3 types of stem cell transplants. So it's allogenic, which means you're getting your own stem cells. Autologous. Oh, sorry, I messed you up. Don't write that down. Cross that out. Okay, allogenic is from someone else. That's a donor. Autologous is to yourself. And then she said, put a big star by the syngeneic, I don't know how you say it, because that can come only from an identical twin. So those are the 3 places you can get a stem cell. And she said put a big